questions, and I'll be expecting my worthy panelists to answer those questions. And these are very basic questions for all the ophthalmologists, general ophthalmologists who are sitting here. Sir, may I start? Sir. So the first question is, what is the right age for refractive surgery? Sir.
I'm going to start off because it's the easiest question which can, so that I'm free. I must say, the FDA has approved from age of 18 till 50 years. That is what they have said so. And the main reason is below 18, it is still that the eye is in a developmental stage, so that is it. But the ideal age where they normally people say is that after 20, we normally do it. But sometime you may have to do it early as possible, just because that person has to go for some selection in army or things like that. But I think so the most important question is the stability anyway. And that is my answer, and please don't ask me again. It's 50 years what they have said, but if you ask personally, I think so everybody has crossed that limit. I still remember I've done on 56, 55. I am sure about other people also being.
There is no upper limit as per my opinion. And I've done it in a patient at the age of 85, anisometropia post-cataract surgery. So basically, yes, you can do it at any age. And if the patient is willing, the last week a patient came at the age of 50, no cataract, no lenticular changes, and he is adamant he should get rid of his far glasses. So if you counsel them as nicely as you could, and if he's ready, he'll get a near problem, and he's ready to wear glasses for near, you can do it at any age. I don't think there is any upper limit.
I have done it on 80 in a patient of 80 as well, as Shareef Hashmani sir was saying, anisometropia.
Was it a phakic patient or a pseudophakic?
Pseudophakic. But normally my cutoff is 45, because then you get lenticular changes if you are dealing with the phakic patients.
Does the cornea behave any differently at a later age, or is it the same as a younger cornea?
I have something to say. So even in Nepal, we have a lot of people joining the army. So what happens is the lower prescriptions are usually, I'm happy to treat with normal scans. I'm happy to treat from the age of 18 to 22. But the moment the prescription goes above -5 and 6, I would really like to wait till the age of 25. So even if the scans are all right, because sometimes you don't know what is hiding. Ectasia can sometimes just come up at the age of even 25, like, you know, you can see things. So this is the reason sometimes many countries, they like to do surgery, they like to start only after 25. But usually, for me, lower prescriptions, 18 to 22, 23, and higher prescriptions, I like to wait after 25. And the upper limit, again, nowadays we get so many refractive surprises, and the patients are so demanding that you can go up to even 80. Like.
So
in the sense that the cornea can be changing till 25.
So I believe the final consensus is that the legal age is 18 years and above. Although certain countries, they have kept this limit at 17 for those who have to join army, but legal age is 18. And stable refraction during the last 1 year, no change in refraction of more than 0.5 diopters during the last 1 year. And as Dr. Kishore already said, that we have to wait for patients who are high myopes. His cutoff limit is 25 years, but it has to be above 20. 25 is a very good age. And I remember that we had a patient whom although she was minus 4.5 or 5, I don't remember exactly, but she came back after 5 years and she had regression. And when we checked, her axial length was increased. So we have to keep in mind that if it is done at a very early age, then there is a possibility of change in refraction later on even. So next question is, what if the patient is a chronic contact lens wearer?
No issue. So chronic contact lens, I suggest that they should wait. And normally what I do, I give a lot of lubricants. I give vitamin C, I give vitamin D as well. I tell them to wait, just quit using contact lens for 2 weeks. If they are chronic contact lens, then I say at least 4 weeks for them to wait, a lot of lubricants, a lot of vitamin C. And then I go for repeat, because there is a lot of difference when you repeat the topography after 6 weeks or so. Even if there are changes and I think then that there is tear film instability, then I would advise to go for repeat topography after even 3 months. So then the results are much better.
Great.
Yes, whatever Dr. Munira said, we follow that protocol. But apart from that, I also go for epithelial mapping. And if epithelial mapping shows that this is a contact lens wearer and there are changes there, so we put them on artificial tears for a long time. They're about 2 to 4 weeks. And once those changes are gone, then we go for LASIK.
I think the main point is you can't do pre-op refractive checkup if they are wearing contact lenses. I think that should be a take-home message, that they have to remove it for a couple, whether it's 1 week or 2 weeks, which is the ideal situation. But you should not try to take those readings or do measurements and then go for those. I think so. We have to make sure that all the things, because the more they are mirror, they may have a dry eye, they may have got vascularization, they could have anything. That has to be sorted out before you can do it. That is my take.
Yeah, with the chronic contact lens wearer, I've noticed that there's a peripheral neovascularization. And we have to take care of it, because when we lift the flap, the blood is going, there's a bleeding, and when we bring back the flap, we have to take care of that no blood should go into the interface. Otherwise, it will lead later on to the more chances of DLK and flap-related problems. So that's during surgery that one has to take care of. So it's better to wait for a longer time, so the vessels should regress a bit.
I'll be asking every question from Dr. Kishore because we want to hear your experience too.
Okay, so the confusion comes when you have a patient coming from very far off. For example, you have a festival in Pakistan and a patient comes all the way from UK and the patient has 3 weeks. Then you don't know what to do. So I have a lot of patients who come from the UK or the US or Australia, and they have come for 2 weeks. In about a week's time, the corneal topography is very stable with soft lenses. We know that. But the only thing that's changing is the epithelium. So sometimes it can take months for the epithelium to really stabilize. And then I have a nomogram that will calculate what your real epithelium should be after surgery. So you know the amount of regression that is going to happen so that you don't undercorrect your patient. For example, if you're doing surgery on an epithelium that is thin, and then when the epithelial remodeling starts off, and then you realize you've undercorrected the patient by about 0.75 diopters. So that is the biggest fear. So you know where your epithelium is on the thinner side, you can actually push your refraction a little bit. Sometimes you know now the epithelium remodeling, the epithelium is going to take a long time to come back to shape because the patient has worn contact lenses for 10 years or 12 years. And the scans are normal. You know when you flatten the cornea, the epithelium will slowly become thicker and thicker and thicker. And then we realize that the regression is so much more than expected. And the patient is going to be under. That's the main thing where epithelial regression, the epithelium remodeling leads to regression. You can calculate that even before. So sometimes I can calculate that you need to push the patient about 0.75 diopters and even treat in about 2 weeks.
From patients coming from
That's
UK,
the best thing.
that's the best thing, actually.
That's the best thing to be on the safe side.
Because to extrapolate, it's not always ideal, I think.
So you take the epithelial images first, epithelial mapping
Yes,
first.
I use the OptiView and the MS39
Right.
to do the epithelial mapping.
Is that nomogram which you are holding, does it hold for OptiView or with also for MS? Or it's the nomogram can work in both?
The nomogram is talking about the epithelial thickness only, not the scanning system. So we know what the nomogram, the epithelial thickness should be, and after surgery what it should be. No, this is a nomogram with Dan Reinstein. I can share it with anybody. Okay, so I can share it with anybody. He would be happy to let you all have it also. And it also helps with a lot of planning with your normal treatments also, not only with the epithelium. Your post-op case and your post-op refraction where it should be. It's something very, very... So what we really have to understand over here is the two things, that is regression and progression, are something else. So progression is your power increasing because of so many things. The size of your eyeball and whatever. Regression, it will happen to every patient. The moment you flatten your cornea, the epithelium is going to start filling it up. So depending on the age, the power, and the K readings, you can calculate the amount of regression that's going to happen. In about 3 months, this is the amount of regression that is going to happen. That is very important to calculate. The moment you know that, your retreatments will come down to almost zero. I do about 1 retreatment in every 2 or 3 years. So it's quite a big of a hassle to retreat someone. So after the surgery, the epithelium is all different, and you want to retreat either with a LASIK or a PRK, or transepithelial PRK. It's so difficult to put which value to put in for an epithelial thickness. Or what thickness flap do you want to make? Because a normal epithelium is about 50 to 52 microns before surgery, and then suddenly after surgery the epithelium is 70 microns or 65 microns. So I think retreatment should be, we try and avoid retreatment as much as possible. So I think it's very important to understand the epithelium. It is one of the most important factors that really help with your post-operative regressions and management. So many people, they also do an A scan. So nowadays the world is moving so ahead. So the patients also know, why didn't you calculate my regression already? They know about it. So they also do an A scan. That doctors, to be on the safe side, they will tell you this is not regression. We've already calculated a regression. This is progression. Your axial length has increased. So it's very important to also do an axial length and keep it as a record. So sometimes you think, the patient will tell you, why didn't you calculate that? So this progression is something you cannot calculate.
Very, very interesting about epithelial mapping. You're using it very nicely. My question is, do you do it only in custom Q and wavefront optimized LASIK, or in every?
No, every patient.
No, the Contura patient, that can Contura this software, it calculates already the future epithelial this thing, remodeling and everything. So do you do in Contura patient also, or only in others?
I've not used the Wavelight or anything. But I think even with the topography guided treatments, with the MEL-80 or MEL-90, there is going to be some amount of remodeling. But I don't know how accurate.
But that takes into account the contour treatment that we do it on wave light, that do take into account the remodeling of the epithelium also.
But the machine which you have got doesn't calculates or measures the epithelium. How can you calculate it? The Contura just thinks it is just a matter of it's a hypothetical, theoretical calculation. It is not on the specific on that patient how much thickness it is, because that your oculizer or anything they don't check the epithelium thickness of that particular patient. That is the point which is putting up.
Excuse me, I have two questions regarding chronic contact lens wearers. One is the corneal warpage, which is different in hard contact lens users and soft contact lens. And practically speaking, how much time you will allow the patient to settle or resolve that process before contemplating the refractive surgery? And second is giant papillary conjunctivitis, and that is another important issue. How much time we will take if the patient is admitted for refractive surgery? Thank you.
I really didn't get the question. Actually.
What was your first question?
My first question is regarding the corneal warpage that is in a chronic contact lens users, and there may be soft contact lens users and hard contact lens users. So how much time you will take for those patients who are willing to do a refractive surgery? So how much time you will tell them to wait before the corneal warpage that took place, it resolves or settles down and the refraction becomes stable and he gets 6x6 vision?
So for me, it's not about time. So for the soft contact lenses, I do the first treatment, I think there's a warpage, I do the second scan, and I see if the scan has changed. I call the patient again back for another. Because till your scans are changing, you cannot go into surgery. So for soft contact lenses, probably 1 week. Like if you do your first scan, and in the second scan, if the scan is stable or has changed, I call the patient for second or third scan. And if it is very stable for about a week with the soft lenses, I'm happy to go ahead with surgery. But again, warpage is like suspicious corneas. You got to be really, really careful, like, there could be something hiding there. Whenever I treat my patient, I always treat my patient like if this patient was my son or my daughter or my father or my uncle, would have I gone ahead? So this is something we all have to think. Like every patient has to be treated like your own father, brother, mother, sister, like that. Then you know how much time to wait. If I'm happy, if I know that the scans haven't changed for a week with the soft lenses, I usually go ahead with surgery. But with the harder lenses, I would like to wait longer. You don't know, they can change. So probably almost a month. So you have to understand why are they wearing harder lenses? Because probably there's some irregularity in the cornea. It's better to wait. So in fact, most of my patients who are wearing hard lenses, they're the ones who get cancer. I don't take any chance. Something is not right, with these patients.
Sure, just one point. What the audience is interested in is as a sort of a standing operating procedure.
Sir, mic, please.
Mic, nahi aa raha? Can't you hear me?
Awaaz nahi aa rahi.
Okay, I'll speak louder. How's that? Yes. Okay, so most of the audience here, young guys, they've been taught that if a patient comes to you who's a contact lens wearer, and when we say contact lens wearer, we are talking about soft lenses. Basically, a young lady who wears contact lenses hardly wears any spectacles. The classic understanding is that the patient should stop wearing contact lenses for at least 2 weeks, every patient, and then you do a scan. So in your practice, is that your norm, or do you assess the scan and look for any changes and then decide whether to proceed or not to proceed?
So
I hope I
understood. Like the patient is a chronic contact lens wearer, and you've been off contact lenses for about 2 weeks.
Our patients walk in wearing contact lenses.
No. Those patients we wait.
Okay.
it's better not to take any chances. You know, the epithelium is different, the corneal shapes are different, and suddenly they'll come back for surgery after 1 week. The keratometries will be different, everything will be different. It is always good to wait, not rush.
Okay. So 2 weeks or 1 week?
1 week,
One
for soft lenses.
Amir?
Actually, Kishore is absolutely right, but I depend more on epithelial mapping for contact lens users as compared to pentacams and Villeli, because epithelial mapping is far more of value in specifically people using contact lenses.
So,
That's
We talked about the epithelium so much.
okay. So, as already discussed, we have to stop contact lenses at least 1 week before preoperative assessment, but we have to be very clear about it that now there is a role of epithelial mapping in refractive surgery. You cannot go ahead without doing epithelial mapping, especially in those with chronic contact lens users or contact lens users. Slide आप इसमें please display कर दें. ये slide यहाँ पे please display कर दें. So when you do epithelial mapping, you will find, or when you do pentacam scan or any scan, you will find a hot spot with epithelial hypertrophy. And when you do epithelial mapping, you will find hot spot with epithelial hypertrophy on that too. So you have to keep on repeating the scans till the time that hot spot is no more there, as already explained by Dr. Kishore in detail. So we all know that it causes irregular astigmatism, changes in corneal thickness, etc., the effect of corneal warpage. Now coming to the next question. Preoperative cycloplegic refraction, is it mandatory? So we'll start with Dr. Amir Israr.
For me, yes. I always do that.
Do you do cycloplegic refraction in every patient?
Every patient. That's
With cycloplegia or cyclopentolate or with tropicamide?
Cyclopentolate.
Cycloplegic.
Tropicamide would not give us cycloplegic refraction.
Sorry?
Tropicamide would not give us a cycloplegic refraction.
Yes. I do cycloplegic refraction all the patients, but the treatment is not based on the cycloplegic refraction again. So this is just to make sure that the patient is not over-accommodating or something like that. You know, sometimes it's very easy. You take a patient on the autorefractometer and we take 3 readings and you get -6. But sometimes you go 10 readings, it goes to -4, and 15 readings, it's suddenly -3. So it's very important that the patient on the autorefractometer itself can be very relaxed. You know, you keep on doing and the accommodation is suddenly relaxed, and then from -6 is come down to -. So that gives you a very clear idea that what's happening. The patient is over-accommodating. But I like patients who accommodate. They are the ones who really have good vision actually after surgery.
I'm not very strict about doing every cases doing a cycloplegic refraction until unless I find that they have got a refraction which is the optometrist. I think so you need to have a very good optometrist also for this kind of a work if you're not doing it yourself. Whether the number is different, for the subjective and objective is different, are younger and hypermetropic, I will always go for a cycloplegic refraction. For myopics, if they are stable and if you find out that they're wearing glasses, already wearing glasses, and they are fine for last 4 or 5 years, and all the tests which we have done are all in the same manner, I think so. Most of the time I have to do it, but you have to look for all the things which you have said before. One thing is for myopics or accommodative spasm, if you feel, then I would go for cycloplegic, but not all the cases.
I agree with Dr. Mazhar. In hyperopic patient, it's mandatory. I do it in all the cases in hyperopic patient. But in myopic, if the myopia is stable, I don't do it, no cycloplegia. And I do it on manifest refraction.
Sir, mic please. आवाज़ नहीं आ रही.
My thinking is same that I do in all hyperopes, but in myopes, if it's variable, our optoms are very much trained, and if it's slightly variable, then they are trained कि उनको cyclo करनी है even in myopes. So if
my
in any
next question
suspicious
is,
case,
we have to see retina fundoscopy of every patient. So why not cycloplegic and see the retina and do the cycloplegic to counter check if the patient has any problem in refraction or not?
The only reason why I won't dilate him, because if I see a retinal break or something, then I have to treat him first for that and then go for the surgery. So it's better not to see at all in a lighter tone. But I think so it's well, if you have to dilate that patient, and why don't you do it? That's a good answer, but that means you're not going. The only thing is that most of the time the patient walk-in patients are also available who want to get done within a few days. So that is also a problem. That is a commercial bit involved in it, that the patient would like to do is they come in, want to get their test done and get the surgery there. So if you dilate them, you can't do it. I mean, these are the practical problems which I'm telling straight away. But you have to be sure about this thing, that whatever you have done, you are sure that you have done it correctly. And if you feel there's any lack, then you can always dilate it.
Question, sir. Question for Kishore.
So I'll answer that one more time.
Okay.
So the reason I do cycloplegic refraction on all my patients is, one is the legal aspect also. So I do refraction for all my patients. So I understand most of my refractions, the nomogram, everything. But then 1 in 100 or 500 patients, one person will land up with something, and that'll be again one of the most difficult patients. Will give you sleepless nights, you don't want to eat, you don't want to sleep for many, many days. So it's for these kind of patients, it's better to have a cycloplegic refraction in case, there are some patients who come to you with your phone record, the recorders are on, and whatever you're talking nowadays, they're recording everything. The moment you say something out, and they will be showing it to everybody. See, this is what the doctor told you. So I think for me, it is always to be on the medical legal safety side. Always, you know that you don't need a cyclorefraction all your patients, but it's better to be on the safe side. The world is changing so fast now.
Regarding you prefer patients who are accommodating. Accommodate, okay? You said that patients who accommodate well have good vision post-op. Could you just highlight what you mean by that? And my second question is, does that apply to patients in their 40s also? Your affinity for patients who can accommodate well or who are accommodating. Your remark was regarding manifest and subjective refraction. You don't rely on the cycloplegic refraction. You prefer patients who accommodate well. You like those patients. Yes. So does that apply to people who are in their 40s also?
Yes. Even
because
in the 40s.
Their accommodation is failing.
So
and if you overcorrect them, they'll end up hypermetropic.
Yeah. So even with the 40s, when I see a patient is 40 years old and then they are the ones who are seeing very well with -3 and can see very well with -4 also, and you know the refraction is only -3. I really like these patients. Sometimes if you overcorrect also, they can accommodate. The moment you're accommodating, there are 3 things. One is conversions and pupil reconstriction. So the pupil constriction is very important to ward off all your unnecessary glare and things like that. So younger patients who accommodate a lot. So most of if you look at my nomogram, looking at the age and the keratometry and the amount of refraction they can accommodate. So 17 or 18 years, not 17 years, 18 to 20 years, most of their post-op day 1 refractions are 1, 1.25 plus. And they're really, really happy with it. They can easily accommodate everything.
And especially after 40, I would certainly suggest that we should do the cycle, because usually what happens is like myopia is already receding and they're using their previous glasses. And you're in a fix if you overcorrect them. They won't be good for distance and will be bad for near as well. So it becomes far more logical to do a cycloplegic after 40.
So we don't have the luxury of overcorrection in patients over 40.
So, in short, we have to do cycloplegic refraction in every patient, especially to rule out accommodative spasm, especially in hyperopes with undetected latent hyperopia. Sometimes we see overcorrected myopes. So when you are seeing the fundus of the patient during the examination, so it's better to do cycloplegic refraction to and check then and then followed by PMT after that. So another one of my favorite questions is refractive surgery in pregnancy and lactation. Is it allowed or not? Can you please close the door?
चलिए मैं शुरू कर देती हूँ. Strictly prohibited for me, and I think it should be क्योंकि in pregnancy your tear film height changes, your corneal thickness may change, even in lactation. मैं 1 year तक तो कहती हूँ कि don't go for it. फिर उसके बाद जब आप पे top feet पे या उसके बाद आप normally तो आप 1 year के बाद बहुत कम लोग करते हैं feet. तो pregnancy definitely a big no for me, and even in lactation 1 year. It's my criterion because of tear film height, because of corneal changes, your map changes. So why should? और फिर मेरा काउंसलिंग पे होता है आपकी. आप पेशेंट से कहें कि अभी ज़रूरत क्या है. मतलब it's your counseling. The patient will turn back to you. जो commercial की भी बात की थी और बहुत सारी चीज़ें बात की. But I really liked your answer कि whatever patient we are doing, but I have done LASIK on my sister as well. So उसको उसी तरह लेना है कि जी she may be my sister as well. It's like that.
Madam, इससे relevant सवाल है. There have been studies that there are similar changes during the menstrual cycle. So, is there any take of the panel regarding this?
Dr. Kishore, please.
So, the menstrual cycle, I'm not very concerned about. My real concern in pregnancy is there could be, this is a very debated topic. So you can do surgery, corneal topography is changing, not changing, cornea has become swollen, not swollen. What, again, is your sister having surgery? Would you do surgery on your pregnant sister or not? If yes, why? If no, why? Because yes, okay, you're so overconfident that she's going to be absolutely fine. Or you're acting like God and you know, okay, she's not going to have keratitis. Tomorrow if she has keratitis and you've got to give her steroids and you have to give her oral antibiotics, would you want to give oral steroids, oral antibiotics, or even immunosuppressive on patients who are pregnant? This is not only about the eye. Suddenly the patient has so much of DLK or something like that, and you have to give so much of steroids, something like that comes up. You know, you get autoimmune keratitis there, inflammation, which is not infective, and in day one you have big keratitis, marginal, and then suddenly you have to give steroids. You cannot give steroids in pregnancy. What do you want to do then? So this is the safety side. Not only the power changes and all that. That is there, the power can be there. You know, power is you wear glasses, you are happy. Suddenly you're a pregnant woman. Do you want to give steroids? Do you want to give oral antibiotics? Or do you want to send this patient to somewhere, or rheumatologist, develop autoimmune keratitis and then start on methotrexate or something? Yeah. All these. So no hassle, no pregnancy. Stay away from pregnant women. You don't know, the hormones, they're responding in different ways. And we men are the worst to understand, I think. You know?
That was the best line, I guess. Dr. Amir Israr, you want to add something?
Yeah, I'm concerned, but not like this is not an absolute no for me. I basically discuss with the patient. I look into it. I always discuss we might need a retreatment or enhancement. And I think if the patient is agreeing to it, now looking at it, as Kishore's mentioned about like how much do DLK we see in our clinics, how much refractive surgery complications we see in our clinics. For me, when I balance them out, it's a discussion and an understanding between the patient and the doctor. And if
patient will always want to have a refractive surgery no matter
if they
what.
are willing and they are understanding, I would go ahead.
Don't you
I
think
don't
it's...
have any.
My question would be this thing. If you, let's be very frank about this thing. If I am in USA and if I do LASIK on a pregnant lady, I'm sure that they are going to take me to court and it's absolutely correct. It's absolutely, I can give you any kind of a answer for that, because we had last time we also had a discussion on this thing, because this is, they have written it in their FDA approval that in pregnancy you can't do LASIK. I've got nothing, this is, everybody has got his own thing, but this is very much clear that if you do a LASIK, I'm sure about in America, that case can be a medical legal case, whatever the reasons are. This is very much written in it.
So, for the general ophthalmologists who are sitting here, please remember it's an absolute contraindication. You cannot go ahead with refractive surgery in pregnancy or lactation. There are hormonal changes. There is a biomechanical instability, and it's been proven with different biomechanical studies which have been carried out in world. There is refraction instability, increase in corneal thickness, increase in corneal curvature. There is an increased risk of ectasia in pregnancy and lactation if you do it. So we have to wait at least 3 to 4 months after cessation of breastfeeding. You have to wait. You cannot even do it during lactation. So this is the take-home message. That is the reason I said earlier this is my favorite question.
And another way I can just take it, there are a lot of young ophthalmologists sitting here, and those may be sitting for the fellowship exams, or if they answer, if there's an MCQ on this thing, and if you say it is, you can do the pregnancy, it's a false answer. It's negative. So I'm saying, if you have an MCQ question in your exams, and they say okay in LASIK, then you are failing.
सर को ब्रिगेडियर बना दिया आपने, जनरल मजहर इसहाक हैं. ये कौन है पीछे? This is not acceptable. जी? हाँ, ज़रूरी है सर. So the next question is refractive surgery in glaucoma. So can we do refractive surgery in a glaucoma patient? Primary open angle glaucoma, angle closure glaucoma, any kind of glaucoma.
For glaucoma, I'm not very much convinced about.
You are?
I'm not very much convinced about going in for surgery in glaucoma. Main reason being, after refractive surgery, we are not able to monitor the intraocular pressure very well. So that is the only contraindication for me. If we have got tools that can basically assess intraocular pressure after refractive surgery, I would be very much confident in doing refractive surgery for glaucoma patients.
For me, it's a yes and a no. You can do, like I've seen some of my American friends who've done refractive surgery, but they always carry a big bag of medicines. Probably they have 2 glaucoma medications, and they probably have another 2 lubricants. That's 4 medications. They're on and on all the time. So I don't know, there's a surgeon, his name is Dr. Paul Imperia. He's a refractive surgeon, and he had glaucoma, and he had LASIK on himself. And we've been running around in the mountains of Nepal doing cataract surgery. But he always had one big bag of medicines for himself. Again, monitoring intraocular pressure, that is manageable. But the other thing is that really confusing is your visual fields. The visual fields can be like every time you do a visual field, you can get excellent results with sometimes a big scleroma, a small scleroma. This can be really confusing. So looking at the life of a glaucoma patient, they don't want to put the glaucoma medication, and then you have lubricants you add on them. It really confuses them so much. So I think more than getting rid of the glasses itself, I think you're giving them more burden of more medicines, you know, and then you're confusing the glaucoma surgeon also. What has he done, you know, and then all the reports. Sometimes I'm not very keen on doing, it's not that you cannot do, but I think I create more problem for the patient. I think that's how it is.
Not all the glaucoma patient, yes, but we can select patient and there's no absolute contraindication.
A big no for glaucoma other than primary open angle glaucoma, a big no. Angle closure and pseudoexfoliation or pigment dispersion, any other than primary open angle. For primary open angle, even I'm not very keen, just like others said, but in mild glaucoma changes that I get, and if the patient will be following me up so that I can be able to gauge the IOP, then I have done it, and this is the practical that we do see कि बहुत ज़्यादा keen होते हैं कुछ कि नहीं जी कराना ही है और early start है, then I follow them up. मेरे पास 20 years से follow हैं, मतलब जो glaucoma के भी थे primary open angle, and I am gauging them, तो ठीक है जब तक जिंदा हैं करते रहेंगे. So it's a relative contraindication for primary open angle for me.
Regarding glaucoma, the angle closure this is totally contraindicated. Similarly, congenital arjuvinal glaucoma. In primary organ glaucoma, you do 2-3 things. Either he's steroid responder, this is important. Number 2, if he's mild glaucoma, mild, moderate, and severe, and mild everybody, you can go for these things. And secondly, if the patient is on prostaglandin like this thing, then wait and change it to another one. So primary will be mild, and if he's not steroid responder, you can go for refractive surgery.
Thank you very much. So this is a relative contraindication. We have to keep in mind that we can go ahead in patients who have mild glaucoma with no visual field defects, nothing, no scotomas, no visual field defects, no existing optic neuropathy. But we have to again keep in mind, as Dr. Kishore said, that we have to, a patient might be using a lot of medicines, effect of medicines, dry eyes, refractive surgery is inducing dry eyes. Then if it has post-op steroids, use of post-op steroids, then some might come up as steroid responders. So there are many things which we have to consider while going ahead in patients who have refractive surgery, who have glaucoma. And another thing which Dr. Amir Israr pointed out, that we'll be changing the corneal thickness. So we have to counsel the patient. So बहुत दफ़ा ऐसे भी होता है patients कहेंगे कि जी हमारी refractive surgery और IOP control हो गया. ठीक, so that thing has to be kept in mind, that patient has to be highly educated with high IQ जिसका आप कह रहे हैं, so that he or she can understand कि जी refractive surgery का ये मतलब नहीं है कि you have controlled the IOP. So these things have to be kept in mind, and then when you do the docking, you are increasing the intraocular pressure. So it is also said that if you are planning to do refractive surgery, so PRK is better than LASIK or SMILE. So there are many controversies about it.
Again, there are few seats in the front if people would like to come in the front, I think so. If somebody likes to come in the front.
Please. So next question is, can we do refractive surgery in a diabetic patient? Sir.
Again, I think so. It's a relative contraindication. If you see it in a very early diabetic who has got no diabetic changes at all, or I think so, and he's a good, well-controlled diabetes, you have to tell him all the pros and cons before you attempt it. I'm still, I will take all the precautions. Tell the patient that if you are sure about it, that you can have a good control, diabetes can affect it, but I will never encourage him, any diabetic patient, to go through it. And if it is somebody who's uncontrolled or somebody who has got some changes in the retina, it's a contraindication, complete contraindication.
Dr. Kishore, please.
For me, I do a lot of diabetic patients, but then the tear levels have to be good, scans have to be good, there should be no cataract. Retinopathy, the retina surgeon will take care of it. But the sugars have to be controlled, HbA1c has to be under control, you know.
Can you please, we can't hear you properly.
So I do a lot of diabetic patients, but everything has to be under control. The HbA1c, the sugars have to be controlled for a long time. Make sure there is no cataract. The tear levels have to be good because, you know, these diabetics, the epithelium can be very loose. So with a lot of care, I can do diabetic patients. Again, retinopathy, if there's a lot of retinopathy, I usually don't. But if there's no retinopathy, I don't think there's any contraindication. Even if it's mild? Yeah, even if it's mild, there's mild to moderate retinopathy, I think the retina people can take care of that.
I totally agree with Kishore, because the thing is, I don't think so I would discourage them. It gives them more of an incentive to keep their diabetes in control, and I would certainly go ahead with it. I always discuss with the patients, and I don't see anything like, it's definite, like if it's uncontrolled or there are like other contraindications associated, I would not do it. But it's not like that we turn away them, like we're not going to do it. It's like an encouragement factor for them as well.
So encouragement is very important. Sometimes I just scare them. Sugar increases your flap. Sometimes I really scare them, like, you know, if your blood sugar levels go high, your flap is going to fly off. And they are really exercising and they keep themselves under good health. Like, really kind of an encouragement to diabetic patients to keep themselves healthy.
So you want to add something?
If yes, if all the parameters are under control, why not? There is no contraindication, not absolute contraindication. If the problem is there, but with the very good counseling, that down the line, 10 years, 20 years down the line, he may need lasers, he may need many things due to diabetes. He may develop retinopathy, and so he should understand those problems. He shouldn't blame the doctor at that time. So a good counseling, yes, we should do it.
So diabetes is a relative contraindication. Patient should have a very good control of his blood sugar levels. HbA1c has to be less than 6.5 for minimum of 6 months. No evidence of systemic or ocular complications. No signs of lenticular changes, as already highlighted by Dr. Kishore. And very important thing is that you have to check the corneal sensations to rule out neuropathy in these patients. And another important thing is that it's been said that LASIK is preferred over PRK because of the same reason, because there is slow epithelial healing response, more chances of punctate epithelial erosion post-operatively, persistent defects, and especially haze in these patients. So it's better to go for LASIK if you are planning refractive surgery in a diabetic patient. So dry eye syndrome, is it a contraindication?
I would stay away, absolutely. If it's a dry eye, I would not be going ahead with it.
Mild dry eye, moderate, severe?
Even mild. I would prefer like not to intrude into that. Like, people do take chances. Smile is one of the things that can be done, but not LASIK.
Which tests do you recommend in patients to check for the dry eyes? Can you please close that door? Sorry.
We can start from the slit lamp examination, doing a Schirmer's. You can do like, we've got like the tear-film analyzer. That's a very nice device to actually have, which actually tells us how much the tear film is, and it actually tells us about the meibomian glands and all the things. So you can use, even your clinical judgment can let you know how things are going, even if you don't have all those fancy devices and everything.
For me, I try and avoid dry eye patients, but then mild dry eyes, usually dry eye patients, I send them to a rheumatologist. So hoping that they'll find something and give them medication, and they come back to me saying, okay, I don't want surgery. But there are times where when there's nothing from the rheumatologist, I go ahead with ventricular extraction surgery. And with a very, very thick cap, so almost 160 micron cap, hoping that there's going to be less dry eye with that. I mean, a very thick cap, avoiding all the corneal nerves.
And do you have anything like once you're going down 160, how much tissue bed you've left? So do you have like a specific dioptric power that you can treat with, or?
Yes, so the nomogram that I use is like I try and keep most of my uncut cornea. So the uncut cornea should be around 420, even 420 microns.
420?
Yes.
The residual stromal bed?
No, the uncut cornea.
Uncut cornea, okay.
The stroma is like...
So what about the residual stromal, even if you're doing smile?
275.
275?
Yes.
Okay.
But then I really believe now, again, there are proof facts that the anterior cornea is stronger than the posterior cornea. But then if you have the anterior cornea, a thick amount of anterior cornea, now this is not regarding ectasia, we're talking about dry eye. So dry eye, I like to go very deep down.
What is the average corneal thickness in your country?
The corneal thickness?
Average corneal thickness in your country?
So it depends from 510 to 530. But we do have a lot of people, like we have different groups of people. We have the Mongols, then we have the Aryans, and most of our Aryans they've come from they have the Turkish origin, they have thinner corneas. There's more keratoconus with the Aryan community there. The Muslim community have more keratoconus, thinner corneas. But the Mongol community, like who have the Tibeto-Burmese origin, they have an average cornea. Even if they have thinner corneas, they have stronger corneas compared to the corneas are stronger biomechanically. Now you do a Corvus, like, biomechanically they're stronger. So this is not regarding ectasia, it is regarding the dryness part. I try and go deeper and deeper. But with all the regulations, you cannot go deeper than 160. By the Vision Max, 160 is the max. With the Atos, I think 160 is the maximum thickness you can make. So you cannot go 170 or something, 160. 160 is very, very deep. So with that, I've seen deep lenticular extractions, the dryness is really less.
For 160, you need to have a very thick cornea.
Yeah. But then the nomogram again, I like to have an uncut cornea of 420 microns.
Right.
That gives you a real strength. That makes me confident that you have 420 microns and it's a strong cornea, uncut cornea, with the Bowman's membrane.
Sir.
Dry eye syndrome, very interesting subject. And Dr. Amir said he will not do the LASIK surgery on.
No, I try to avoid it.
Avoid it,
but
yes.
if I have to do it, I do.
Very interesting finding I would like to share with you is we did a research on the prevalence of dryness in Pakistan, in Karachi particularly, and we found that the prevalence of dry eye is about 43.6%, and the most affected people, the age is about 23, I think 23? 23. So if we say no to everyone, the big chunk will be gone. So if we do epithelial mapping in every case, and if there's a dryness there, we treat that, and if the epithelial mapping comes to normal, then yes, we do it, but not in in mild cases, yes, we do it, but not all the cases. Yes, in very difficult cases, we don't do it. But in mild cases, yes, this is not a contraindication. I would like Dr. Nouman to add in this subject because he has got a very good research on it. So,
before you get I think so. It's also important that if you have got clinically, if you can't, doing a shimmer test can help a lot. It's a very simple test and can give you an idea of what kind of a thing it is. But I think so. Everybody agrees on this thing that if the dry eye is not causing a problem, we can go ahead and do the surgery. But if there's a severe dry eye condition, then I think so that.
I will agree with Dr. Shareef Hashmani that if we are going to, for a dry eye analyzer of this whole audience and our panelists, then 40 to 50% must be having mild dry eyes. This is the norm, normally the pre-existing thing nowadays. So for mild eyes, there are big chunks, so I just treat them. We have got dry eye analyzer, as well as we have got treatment modules for that. And for severe and moderate, yes, very cautious not to do in severe.
Yes, yeah.
So we know that the dry eyes, it affects topography, induces higher order abrasion, affects visual acuity in refraction, change in K reading, thickness, inaccurate biometry. It even affects biomechanics, dissatisfaction after refractive surgery in patients who have dry eyes. We have seen that. So any active disease is a contraindication. That should be the take-home message. We have to treat the dry eyes. You have to check for the dry eyes in every patient, and you don't need any fancy test to check for the dry eyes. You just need a fluorescent strip. You do the fluorescent staining of the cornea and of the ocular surface and do the tear film breakup time in each and every patient who comes to you for effective surgery. That is the way you can rule out all the patients of dry eyes. So coming to the next question, atrophic holes at retinal periphery. So do you go for refractive surgery in patients who have atrophic holes?
I think so. I don't know. Three of us sitting from this edge had interest in retina first and then refractive. They used to, previous life. So I think so. We can very easily answer these questions. I've said if you say atrophic holes, there's a big controversy going on, but most of even the retina specialists are not going to touch atrophic holes, doing any laser on them. And that is, I mean, so this is what has been in most of the retina conferences decided that if you find atrophic holes and you don't find any traction or anything like that on those holes, but if you find tear hole, and that you have to understand there's a difference between a hole and between a U-shaped tear or something like which has got a traction, that has to be treated before you can do anything. So in atrophic holes, the jury is out whether you should wait or see. And I think so the best answer would be that if refractive surgeons, if they should look at the retina, and if they find anything suspicious, should send it to the retina fellows to decide what to do. I think so that is a better take-home message rather than exactly doing it or not doing it.
Sir, I'll add one more question in it. So we have seen patients, those who went to for refractive workup, and then they have been told to go for 360-degree PRP because they have lattice.
That is absolutely wrong. I think so. This is something which is not practiced by the retina specialist at all. That if you find a few small atrophic holes, you should go for prophylactic laser. But unfortunately, in Pakistan, we see a lot of, because it's a known fact that even these minute retinal, wherever you have done the photocoagulation, they itself may become the source of the next break. And I have personally seen a lot of cases like this, that from that break, wherever we have done the photocoagulation, there's a formation of a break. So overall, my take-home, I will always do a laser on which I can see there's a retinal fraction on something, on that weak area, or you can say lattice or anything. If there's a traction over there, or that is a place where you can. But if you don't find anything like that, I do not think so you're going to make any difference in the natural history of retinal detachment by doing a prophylactic laser.
So, Dr. Kishore, we are short of time, so I'll be
I send most of I do my retina checkup myself, but then if I see something like that, I send the person to my retina surgeon and let that person decide. My retina surgeon knows the amount of suction pressure that the laser has. With the Atos, is slightly higher than that of the Vigimax. So sometimes I feel could be that the suction itself also has an effect. But most of the time I see my retina surgeon, what he does is a prophylactic laser, and asks the patient to come back after a month and then examines the patient and then allows the person to have surgery.
So if you have done prophylactic laser around a hole or tear, so what would you would you prefer to do femtolasic in that patient, or you would go for PRK in that patient, or it doesn't matter?
No, I'm more of a lenticular guy, so
You
I'd
are?
love to do.
Sorry?
The lenticular surgery.
Lenticular surgery.
Anyway, but it doesn't make, because the suction will be in both of
Yeah,
them.
with the same.
So
You think that the PRK, the suction is not going to be there?
I'm just asking a question for the
Yes,
audience.
yes. So I would definitely go for a smile or a smart side, a lenticular surgery.
I'll just add on one thing. When we were using microkeratomes, those were the things which really had high pressures. So those were like things when we used to avoid and convert LASIK patients into PRK. But now with femtolasic, since it's a very controlled type of a suction, so it seems quite safe once we've done the laser thing. So I don't see any reason why we should not go into femtolasic once we've lasered the retina for the weaker parts, as General Saab said.
The reason for asking this question is that patients come and they ask that we have been told by a doctor that because you have gone, you have had a PRP around the hole or lattice, now you cannot have femtolasic. So that is the reason I asked. So this is not a contraindication. You can still go ahead with femtolasic or PRK or lenticular extraction even after a prophylactic laser. So as already discussed, lattice, it doesn't require any treatment. You have to observe a follow-up, counsel the patient for regular follow-ups. However, if you find a tear that definitely needs prophylactic laser, but that too around the tear or hole. And we have to wait for at least 2 to 3 weeks. Some say we have to wait for 4 weeks. I normally wait for 4 weeks. I'm a very underconfident surgeon in that regard. But if we ask vitreoretinal surgeon, they will say that you can even wait for 2 to 3 weeks and go ahead.
Because it's a wave that patient gets in
PTA, percentage of tissue altered. I think my panelists are tired now. So we have half an hour before the next session
the PTA,
starts.
the percentage of tissue that is removed, that's what you're talking about, right?
So, yeah.
So 25%, not more than that.
Sorry?
25%. You cannot remove more than 25% of tissue on the nomogram. That really thins out. See, the cornea itself is about, when you're talking about 500 microns, it sounds like 500 microns. But then when you talk about half a millimeter, it's like, when you think of it, it's just half a millimeter thick. And then again, you take out more than 25% of the tissue out of it. It's going to really, unless, the two things that I really look into is, even if you have more tissue left behind, for example, you have more than 420 microns left behind, but the percentage of tissue that's removed is more than 25%, that makes that person very vulnerable to ectasia in future.
Most of the time, residual stromal bed is seen. Okay, we have residual stromal bed of 332 micron, so it's above 300. Oh, patient is perfectly fit. No need of calculating anything else. So do you think we can go ahead with 332 residual stromal bed, or PTA has a role?
PTA is not only regarding ectasia of the residual stromal bed, it is also the amount of contour change that you have done on the cornea and the visual quality that will affect. So more than 25% of tissue, the amount of aberrations that you're going to induce, the amount of flattening that you're going to do on the cornea. I think the ectasia part, but also the amount of the visual acuity thing. I wouldn't go, my nomogram doesn't allow me to go more than, and this is a nomogram by Dan, right?
One cannot take PTA as an independent factor.
Yes.
It has to be like combined with other factors.
Other factors. It is not an independent factor, like, you know. So sometimes you have a very 10% tissue that's coming out, and then you have your RST is less, or your post-op corneal thickness is less. Okay, so it can be, this has to be analyzed in a group.
PTA, this is the Santiago one. Santiago's basically, he made this PTA, and what he has came up with is that if it is 40 or something, 40 is
less than 40.
40, less than 40, and if it is the maximum cases of ectasia which he found out was those who have crossed 40. So that is the basis why PTA came up. And now they have come with PTA plus also, I think so. And they have also shown, I think so, as Amir said, you have to take all the factors. But I think so, this has been proven, there are a lot of papers on this thing, that this is one of the things, I'm saying, there may be other criteria which is in the pentagram also which can give you answer. But I think so if you see it is covering over 40, that means you have to be very careful. You have to bring it down, but different means, whether you reduce the optical size, if it is possible, whether you reduce the corneal, the flap thickness or this. So these are all, but it gives you a first eye view that yes, there's something wrong, and you have to think about it, what it is.
Basically, you're absolutely right that we have to take cautions for all the things, but one of the lectures that I attended of Cynthia Roberts about Corvus and Pentacam, she actually showed a lot of interesting patients, nomograms and everything, who never had anything wrong, but they developed ectasia 2 to 3 years down the line after refractive surgery. And there was nothing that could be indicated pre-surgery, but they developed it. And then she showed quite a lot of cases who had a lot of things wrong, and they had refractive surgery and nothing went wrong after that. So still we are confused, who's going to develop ectasia following refractive surgery or not. Although we have got quite a lot of absolute and relative contraindications, but we cannot 100% say that we are right on the tip of the iceberg to detect all those cases who are going to develop ectasias post-refractive surgery.
So we should not consider this PTA? Do you mean?
This is not what I'm saying. I'm saying we should consider PTA, but do not forget that PTA is the only important factor.
Yes, that should be the take-home message, that you have to take many things all together, not just one residual stromal bed or just one PTA. Sometimes you can have a good residual stromal bed and you can have a bad PTA. Sometimes you can have a PTA and the residual stromal bed which is in limits, but then you find out that you are flattening the cornea too much, more than 34 diopters, which is not recommended. So you have to keep everything side by side. So percentage of tissue altered, it has to be less than 40%. Dr. Kishore, according to Dr. Kishore, it has to be not more than 25%. So there are many discussions and many studies which are coming up. But for you people, you should at least keep in mind that it has to be less than 40%, and you have to calculate PTA in each and every patient along with other flat K as well as the steep K or the residual stromal bed. So how do you calculate it? I have kept this slide that if, for example, you have a PTA of 43%, you can play with the flap thickness, you can reduce the flap thickness, you can reduce the optical zone, and you can reduce the PTA in such patients. Like in this example, patient has 7 diopters of refractive error, and flap thickness was 120, and when you calculate PTA, it is 43. And just by reducing the flap thickness to 100, your PTA comes down to 39%. So this is the way you can play with your PTA. So post-operatively, you saw impurities beneath the LASIK flap. Do you think that you should relift the flap and wash it and put it back or you can wait?
I think is like it totally depends upon the type of the thing that is under the flap, its position, its reaction, and whether I like it or not. Then I decide. I just can't put one simple answer to this. But mainly if it is disturbing, if I think it is going to cause a DLK, or it is going to cause any aberrations or difficulties in vision, I would just simply wash it, because washing, going underneath the flap and washing it is not a big thing.
The only thing that I leave behind is microsponge particles and metallic particles. There's fine metallic particles sometimes you see during surgery. They're shedded off from the instruments that we use.
We can't hear you. Can you please?
So the things that I usually take out, I leave behind are the microsponge particles and the metallic particles. The small metallic particles can give you a lot of DLK actually, and if it's quiet, I don't do anything. But other things like fibers or like something else, I usually try and take it out.
I think so that how to avoid is also very important. And I think so when you do a very meticulous wash when you put back the, before you put back the flap. But sometimes what happens is that even if you tell your patients not to do makeup or something, they still have got a bit of a, when you're doing a surgery, you still find surma or some things like that, or we won't call surma nowadays, I think so, nayi cheezein, modern cheezein, whatever they are, you do find a bit of them. And I've found, I don't know, I think so, I give, there's a very good